Welcome dear students, I am Dr. Pratyusha and in this video let us learn about one of the most important topics in ear clinically. If you see 10 cases in an ENT OPD, at least half of them would be of this disease. And yes, you have guessed it right, we are learning about CSOM. CSOM is chronic suppurative otitis media. This is a chronic infection of the middle ear cleft and it is characterized by two important features, and they are: first is an ear discharge that is chronically present plus a permanent perforation. What is meant by a permanent perforation? Some perforations of the tympanic membrane heal spontaneously and some do not heal. And we understand that it is a permanent perforation that has not healed by observing squamous epithelium around the edges. Squamous epithelium around the edges of perforation. Now, why would squamous epithelium be seen? If you know the structure of tympanic membrane, the outer layer is squamous epithelium and the inner layer is mucosal. So, when these two layers come into contact with each other, the outer squamous epithelium is fusing with the inner mucosa. That is when the edges will show squamous epithelium and it is a permanent perforation that is not healing. The fibrous layer in between gets entrapped between these two layers. So, that is a permanent perforation. And CSOM is one of the very important reasons for hearing loss. CSOM is, I can say, the most important cause for hearing loss in patients, and that makes this disease clinically very important to us. Now, chronic suppurative otitis media can be divided into two important types, and this classification is very much essential to understand the nature of the disease. So, what are the two types of CSOM? First type is Tubotympanic type. Tubotympanic type. Now, this Tubotympanic type is also called as Safe Type, also called as benign disease. The other type is Eticoantral type. Eticoantral type is also called as unsafe type or dangerous type of CSOM. Why is this classification there? Because tubotympanic, the complications are very rare. There is no risk of serious complications. Whereas in eticoantral, there is a serious risk of complications. Now, in tubotympanic type, the disease usually affects the antero-inferior quadrant of middle ear. Antero-inferior area. What is present on the anterior aspect of middle ear? If you remember the boundaries of middle ear anatomy, on the anterior side we have the eustachian tube. So, tubotympanic type involves the eustachian tube, which is present antero-inferiorly. Along with that, the mesotympanum is also involved. What is mesotympanum? The middle ear is divided into two parts, epitympanum and mesotympanum. Epitympanum is that part that lies opposite to pars flaccida, whereas mesotympanum is the part that lies opposite to pars tensa. So, these two are involved in tubotympanic type and it is usually limited to the antero-inferior area. Another feature of tubotympanic type is that it involves a central perforation. There are two types of perforations of tympanic membrane, central and marginal, and this is usually a central type of perforation. Active disease, where there is inflammation of the mucosa and mucopurulent discharge is present. We call this a wet type of CSOM. And the second variety is inactive or dry type, where there is no inflammation and no mucopurulent discharge. So these are the two subtypes that are present in tubotympanic type of CSOM. Now let us look at the etico-antral type. If tubotympanic is involving the antero-inferior area, etico-antral involves the posterior-superior area of middle ear. And what is present on the posterior-superior area? Mastoid is present. So the structures that are involved in etico-antral type are the attic. What is attic? It is that part of middle ear that lies opposite to the pars flaccida. Edetus and mastoid antrum. And here we see a marginal perforation or an attic perforation, both of which are dangerous. If it is present in the pars tensa, it would be a marginal perforation, and if it is present in the pars flaccida, we call it attic type of perforation. So these are the features that are seen, and this is usually associated with cholesteatoma. A bone eroding process, cholesteatoma or osteitis, are usually present in etico-antral type, which is the unsafe type or the dangerous type. So this is broadly about the two types of CSOM, tubotympanic and etico-antral. Let us study about each one of them in detail, beginning with tubotympanic type. Tubotympanic type of CSOM remains localized to the mucosa of the antero-inferior part of middle ear cleft, as we have discussed in the introduction. It remains localized to antero-inferior part of the middle ear cleft. In tubotympanic type, the healing process is also very active. Now, the healing and destructive processes go hand in hand, and they depend upon the virulence of the organism and the immunity of the patient. They both are fighting, and whatever is stronger will take over. And acute exacerbations are very, very common. The disease is constantly swinging between active type and inactive type, wet and dry. Wet and dry. The patient remains dry for a period of time, and again there are acute exacerbations with discharge. Now let us look into the predisposing factors for tubotympanic type. Most important, and I can say the number one cause, is a perforated tympanic membrane. When the tympanic membrane is perforated, it is constantly subjected to infections from the external auditory canal. An acute episode of ASOM might have resulted in a large central perforation of the tympanic membrane in the childhood of the patient. And now this perforated tympanic membrane acts as a channel of infection. There could be repeated infections that are occurring from the external auditory canal, either through putting some foreign objects in the external auditory canal or by water that is entering the external auditory canal. The middle ear mucosa is getting exposed to the environment. It gets sensitized to all the allergic substances, pollen grains and other aeroallergens from an environment, and this leads to infection and further perforation. Now the initial perforation could be small, and every time an episode of ASOM occurs, this perforation becomes larger and larger. And this vicious cycle continues. The second source of infection is via the eustachian tube. Ascending infections from the tonsils or any pharyngeal infection could travel via the eustachian tube and cause persistent or recurrent otorrhea. And third factor is allergy. In these patients, usually a concomitant allergy is found either to certain foods or to certain environmental inhalants such as pollen grains or fungi, or dust allergy could be present. It is usually observed. Now let us see the clinical features of tubotympanic type of CSOM, both the symptoms and the signs. The symptoms that we observe are, first and most important is ear discharge. This is usually the presenting complaint of the patient. And how is the discharge? It is odorless. It could be mucoid or mucopurulent, profuse or scanty. It's usually moderate in quantity, neither profuse nor scanty. But what is important is it is odorless, mucoid or mucopurulent. It is not blood-stained. It is constant or intermittent, as I told you, depending upon the stage, whether it is wet or dry, active or inactive. Constant or intermittent discharge could be present. And the discharge is usually seen in the active stage when there is some infection of the upper respiratory tract that has led to an acute exacerbation of CSOM, or when there is some water entry via the external auditory canal. Second most important symptom is hearing loss. The severity of hearing loss differs in different patients. It depends upon the size of perforation and the status of the middle ear. It is a conductive type of hearing loss that is observed. Conductive hearing loss. Now, a unique feature of this type of hearing loss is, in the presence of discharge, the hearing may improve rather than in the dry state. Because in the dry state, the sound waves reach both the round window as well as the oval window because of disruption of the middle ear structures. And when the sound waves parallelly reach the oval window and the round window, they cancel each other and the patient cannot hear. The patient can identify his hearing loss. But when a discharge is present, the round window is shielded. We call this as round window shielding effect. When the round window is shielded, the sound waves only reach the oval window and the hearing is better. Responsible for, now the round window shielding effect is responsible for better hearing in the presence of discharge. These are the only two complaints usually by the patient. One is an ear discharge and second is hearing loss. Now let us see what are the signs that are observed. First is a central perforation of pars tensa. If it was eticoantral, what type of perforation is observed? A marginal perforation or attic perforation. But in tubotympanic type, we observe a central perforation of pars tensa. On examination, we have to identify various features such as size of perforation, whether it is small, medium, large or subtotal perforation. Subtotal in the sense it extends to more than 2 quadrants. Shape of perforation, which could be round, oval or kidney shaped. Edges of the perforation have to be observed, and the position of perforation, whether it is anterior, posterior, inferior, and how do we understand? The reference point is the handle of malleus. If it is present anterior to handle of malleus, we call it an anterior perforation. If it is posterior to the handle of malleus, it's called posterior perforation, and inferior to handle of malleus is called as an inferior perforation. Area with respect to handle of malleus. So a quick revision about perforations. A perforation of tympanic membrane could be a central perforation or a marginal. Repeat. A perforation of the tympanic membrane could be present in the pars tensa or in the pars flaccida. If it is in the pars tensa, we call it central. If it is in the pars flaccida, we call it attic type of perforation. Now, in pars tensa, it could be a central perforation or a marginal perforation. If it is central, it could be present in the anterior, posterior or inferior quadrants with respect to handle of malleus, or sometimes it could be a subtotal perforation involving 2 or 3 quadrants, or sometimes it could be a total perforation where only the annulus of tympanic membrane is seen. So that was about perforations. Here what we find is a central perforation. Next, when we observe the middle ear mucosa, it depends upon the stage of the disease. If we are observing it in the active stage, the mucosa appears inflamed, red and edematous. It could be velvety in nature when the disease is active. If we examine during the inactive stage, when there is no active inflammation, it just appears pale. The middle ear mucosa is pale. And sometimes it could be a little moist. Then we also see polyps. Polyps could be found in the middle ear. What is a polyp? It is an edematous and inflamed mucosa that protrudes through the perforation and presents in the external canal as a polyp. I'll write that down for you. It is an inflamed and edematous mucosa that protrudes through the perforation. And presents as a polyp in the external auditory canal. And this polyp is usually pale. It could be pink in color and fleshy if it was an eticoantral type of CSOM. But in tubotympanic type, it is usually pale. Next on examination is tympanosclerosis. What is tympanosclerosis? The white chalky deposits that are seen on the promontory, ossicles, joints and tendons, and even on the round window and oval window. And this tympanosclerosis can interfere with the mobility of the structures. I'll show you a picture of how tympanosclerosis looks like, but please remember this as a white chalky deposit that is seen on various structures. This is how tympanosclerosis looks like. I can hope you can see the white chalky deposits on the tympanic membrane here. But it could be present on the ossicles, on the tendons, at the oval and round windows also. Next, upon examination, what we find is we have to look at the ossicular chain. In the 3 middle ear ossicles, it's possible that they remain intact and mobile, But sometimes on repeated episodes of acute exacerbations, repeated episodes of CSOM, there could be necrosis of these bones. Particularly the long process of incus is vulnerable to this necrosis. Long process of incus may show necrosis, and this will affect the hearing of the patient badly. Next feature is fibrosis and adhesions. On examination, we could find various adhesive structures and fibrotic tissue. This occurs because of the healing process that is constantly occurring after every acute exacerbation. But this fibrosis can affect the mobility of structures. It can impair the mobility of the ossicular chain, or it can cause a eustachian tube blockage. Ultimately, it's detrimental for hearing of the patient. So, fibrosis and adhesions could impair the mobility of ossicular chain. It can also cause eustachian tube blockage. And lastly, we find granulations. Granulations could be present over the remnant of the tympanic membrane that is present after the perforation, or some part of tympanic membrane is still present. There we can find granulations. And we have to rule out the ingrowth of squamous epithelium from the edges of perforation, because that could be a sign of cholesteatoma. Now sometimes, although very rarely, a cholesteatoma could be present in tubotympanic type also. Along with a large central perforation, a cholesteatoma could be present. So while examination, we have to be alert and rule out a cholesteatoma. So these are the clinical features. Now let us come to the investigations of a tubotympanic type of CSOM. So in investigations again, the first part is examination under a microscope. Examination, our clinical examination becomes the first investigation. And while examining, what all should we look for? I would put that as a list for you. First, look at the margins of the perforation. Then, look for any ingrowing epithelium. This is very important because this could be an evidence of cholesteatoma. Look for any other evidence of cholesteatoma. First, try to rule out the dangerous type. If there is any ingrowing epithelium, if there is some other evidence of cholesteatoma, if there is any granulation tissue or polyp, these are all the things that you should look for. They could be present, they could be absent, but when you are looking, you have to observe for all these things. And then try to collect the middle ear discharge, if at all, if any, is present with a swab. And look at the status of middle ear mucosa. Through the perforation, you can see the middle ear mucosa. If it's a large perforation, you can very clearly see. That will tell you the status, whether it is active or inactive stage. And also try to look at the status of ossicular chain, if it is intact, if it is fixed, or if there is any necrosis that is happening. When the ear is dry, all these changes can be nicely looked at. Then after examination, we have to do hearing tests. And while doing hearing tests, we will get to know the type of hearing loss and also the severity of hearing loss. The type, as you know, is usually conductive type of hearing loss. And the severity depends upon the size of perforation and the ossicular chain. It is variable, but it rarely exceeds 50 decibels. It's usually less than 50 decibels. Sometimes it's possible that the cochlea gets damaged because of the absorption of toxins. And if the cochlea is damaged, then it could lead to sensory neural type of hearing loss, and you will find features of mixed hearing loss, both conductive as well as sensory neural. Then we have already collected the swab from the discharge. We have to send that to culture and sensitivity. This will help us in identifying the microorganism that is causing the infection, and it will also help us in identifying the antibiotics that we have to prescribe. Now, CSOM could show mixed cultures. All types of organisms are possible, aerobic, anaerobic, or even mixed cultures, but the common ones that are usually seen are Pseudomonas aeruginosa, Proteus, E. coli, and Staphylococcus aureus. Among anaerobes, we will find Bacteroides fragilis and some anaerobic streptococci are also found. These are some of the common organisms that are isolated from the culture. After this, even imaging has to be done. We will look at the mastoids. X-ray mastoids is done. Because mastoiditis could occur as a complication of CSOM. When we see the condition of mastoid, we find that it is usually sclerotic. It's usually sclerotic. If at all, if it is pneumatized, we will find clouding of air cells. Clouding of air cells in the mastoid. There is usually no evidence of any bone destruction in tubotympanic type. That's a feature of eticoantral type of disease, bone destruction. Here, no bone destruction. And after X-ray mastoids, we can also perform X-ray of the paranasal sinuses. This will help us in identifying any focus of infection and sinusitis. Now coming to the last part, that is treatment of a tubotympanic type of CSOM. Now first, it depends upon the stage. If there is active otorrhea, if an active otorrhea is present, your discharge is present, our primary aim is to clean the discharge and control the infection. If otorrhea is present, clean the discharge by performing oral toilet plus control the infection. What if you see the patient in the dry stage when there is no active otorrhea? Then you have to look at the damage, about the perforation and about the status of the middle ear, and plan for a surgery, that is tympanoplasty, middle ear reconstruction surgery. Now the advantage of middle ear reconstruction surgery is it prevents further infections from the external auditory canal if you close the perforation, plus hearing will also improve and even acute exacerbations will come down. So in the active stage, conservative management with medical treatment is done, and treatment of the focus of infection is important. In the quiescent inactive stage, if the patient presents to you, you will first rule out infection here also, and if at all, if any minor focus of infection is there, treat that. Treatment of infection if present. And most important is to plan a surgery. What is the surgery? Tympanoplasty. If at all the mastoids are also involved, then a mastoidectomy may be required. Mastoidectomy may or may not be required, plus or minus. Now, in the medical therapy, antibiotics are very, very important. They depend upon the culture and sensitivity reports, but still to give you a broad idea, the most common antibiotics that are preferred are quinolone group of antibiotics such as ciprofloxacin and ofloxacin. We also use steroid ear drops. Dexamethasone is used to prevent inflammation, further damage to the middle ear structures. Ototoxic antibiotics have to be avoided at all costs. And it is believed that maintaining an acidic pH in the middle ear will eliminate Pseudomonas infection, and for that purpose 1.5% acetic acid drops are used. Acetic acid drops are used for Pseudomonas infection. Regular oral toileting is done. And all this treatment is done only when the patient is in the wet stage. After the ear becomes dry, ear drops should not be used because they can again make the ear wet and can initiate discharge, and these ear drops can go very much deep into the inner ear structures also. The ear has to be regularly examined to look for any maceration of the skin, any growth of fungus, or if there is any further new infection or evidence of cholesteatoma. For all these purposes. And most important is, patients have to be instructed very specifically to avoid water entry into the ear. They have to be very careful while taking a bath, especially a head bath, while getting into swimming or taking any water ablutions. The ear has to be adequately protected. The external ear has to be closed with cotton swabs. And second important instruction is they have to avoid heavy nose blowing, hard nose blowing, because that can propel the infection from the nasopharynx into the middle ear. And whenever there is an upper respiratory tract infection, they must not neglect it because it can travel via the eustachian tube and cause an acute exacerbation. Self-cleaning of the ears, putting of any foreign objects into the ears have to be avoided by this patient. They have to be avoided by everybody, particularly by CSOM patients, because that can lead to a new infection and an acute exacerbation. Ear drops should not be used by the patient on an over-the-counter basis because there is a perforation, and they have to be careful. Use it only upon doctor's instructions when the ear is wet, when there is active disease only. So, patient's instructions are very, very important part of the treatment. These things have to be explained to the patient properly. And if at all there is any concomitant infection such as tonsils, adenoiditis, sinusitis or allergy, treatment of them will also help. And coming to surgical management, you already know it is middle ear reconstruction surgery. And if mastoids are involved, mastoidectomy has to be done. If at all there is an ear polyp or granulation tissue, that also has to be removed, because they will block the way of discharge. An ear polyp is snared. It should never be avulsed, because this polyp could be attached to deep structures such as facial nerve or stapes, or even as deep as the horizontal semicircular canal. So avulsing the polyp can lead to complications like facial paralysis, dislocation of ossicles and even labyrinthitis. So it just has to be snared or cut. In tympanoplasty, in a dry ear, myringoplasty with or without ossicular reconstruction has to be done. Closure of perforation will limit repeated infections from the external auditory canal, and it will also improve the hearing of the patient. So this is about tubotympanic type of CSOM. Let me quickly recap them for you. All the features. Tubotympanic type usually involves the antero-inferior area of middle ear, and the predisposing features are a perforated tympanic membrane which leads to repeated acute exacerbations, and the infection can also occur via the eustachian tube, and allergy is usually present in most of the patients. Coming to the clinical features, the two important symptoms or the only symptoms presented by the patient are an ear discharge and hearing loss. Ear discharge is odorless, mucoid or mucopurulent, profuse or scanty, constant or intermittent. Whereas hearing loss is conductive type of hearing loss, and a special feature is the patient can hear better in the presence of discharge because of something called as round window shielding effect. The discharge prevents the sound waves from striking both the oval window and round window parallelly and cancelling each other. They shield the round window so that the sound waves reach only the oval window and hearing is better. And coming to the signs, the first sign that is observed is a central perforation of pars tensa. Then we have to observe for the middle ear mucosa, which is inflamed, red and edematous in the presence of an active disease. Third is presence of polyps, which are inflamed and edematous mucosa protruding from the middle ear into the external ear through the perforation. Tympanosclerosis, that is chalky white deposits as seen in this picture, are observed all through. Ossicular chain can show necrosis in certain patients. Fibrosis and adhesions are found at various areas that could lead to immobility of structures. And granulation tissues, if present, have to be looked for. Coming to the investigations, a detailed examination of the ear is very important. We have to look for various features such as margins. For an ingrowing epithelium, evidences of cholesteatoma, granulation tissues, and most important is the status of middle ear mucosa, which will tell you whether the patient is in the active stage or the chronic stage, and also status of ossicular chain. Then perform hearing tests, which will tell you the type and severity of hearing loss. It's usually conductive hearing loss unless when the cochlea is involved because of the absorption of toxins, leading to a mixed hearing loss where there is both conductive and some sensory neural component. And the severity is usually less than 50 decibels. Then we take a swab from the discharge and send it for culture and sensitivity. What we observe are a mixed culture, but the most common organisms are Pseudomonas aeruginosa, Proteus, E. coli, S. aureus, Staph aureus, and in anaerobic type we find Bacteroides fragilis and some anaerobic streptococci. Imaging has to be done for the mastoids to see clouding of air cells, and if mastoids are involved, destruction of mastoids, bony destruction is usually observed in eticoantral type and not in tubotympanic type. An X-ray of paranasal sinuses should also be done. Finally, coming to the treatment part, if the patient is in the active stage, do oral toileting, and controlling the infection is very important. If you see the patient in inactive stage, still look for any infection and if present, treat it and plan a surgery, tympanoplasty or mastoidectomy if required. Medical management consists of antibiotic drops such as ciprofloxacin and ofloxacin, steroid drops dexamethasone, and to control Pseudomonas infection, 1.5% acetic acid is used. Instructions to the patient are of utmost importance to keep the ear dry and to avoid self-medication of ear drops into the ear. And surgical management, as you know, is meringoplasty or ossicular, if the ossicles are disrupted, ossicular chain reconstruction, a middle ear reconstruction surgery is required. If at all a polyp is present, it has to be snared or cut, but never avulsed. So this is about tubotympanic type of CSOM. Let us look at eticoantral type in the next video. Thank you.